welcome to another episode of Healthy Politics, where we'll discuss the eternal intersection of healthcare in the United States and American politics. My name is Nick Karls. I'm a benefits attorney here at Holmes Murphy. I'm also the compliance director for the Employee Benefits Department. And with me is my esteemed co-host, Den Bishop, former president of Holmes Murphy, and our longtime healthcare strategist extraordinaire. How's it going, Den?
Good, Nick. Let's go.
Let's do this. Yeah. We've had a little bit of a break. It's been about a month and a half. And I think one of the first things we want to talk about was a new study that came out that you were explaining to me just a moment ago.
Yeah, there's a study by Pew Research that came out, and I saw the headline and immediately clicked on it. And what it indicated is that in their study of economic concerns of the American people, that the number one economic concern right now is the affordability of healthcare. It has bypassed debt. It has bypassed inflation and fear of a recession, and has moved there very quickly. If you look back over the last several years, it was not ranking nearly as high as other economic issues. And I think this has very significant motivations for both political parties. I think this will cause the Republican Party to be anxious about making any big changes because they don't really know what to do. And I think it will embolden the Democratic Party to try to seize on a more aggressive government role in healthcare. But I think it was a quiet little study that probably didn't get a lot of attention outside of our industry, but it's a big political indicator of what's starting to cause anxiety for people.
And did it say anything about why it's having kind of that new moment in the sun?
It didn't go deep enough to say why, but I tell you the biggest change, and affordability of healthcare was cited as a very big problem by 67% of Americans. Here's the really surprising part. If you look back in 2021 in the same survey, same questions, 40% of Republicans in 2021 said that affordability of healthcare is a very big problem. Today, it's 61%, over a 50% increase in Republicans. I would expect Democrats to be on this, and 73% of Democrats do say it's a very big problem, but 61% of Republicans. So it's really moved from what was a dividing partisan issue to what is now really a bipartisan issue, because both sides, voters are starting to say, hey, this thing is really becoming a problem.
I wonder if it has anything to do with an aging population, right? The people that are responding to the surveys, the studies, and as people get older, they use healthcare more. The costs associated with it start to matter a little bit more. And so I wonder if there's a tie in there. That's complete speculation.
It could be that, it could be the way that employers have shifted more economic burden to plan participants. So it's, even if you have employer sponsored health insurance, it's expensive if you have to go to the doctor.
The employers are feeling the squeeze, and then as a result, there's only so much that they can, digest themselves, right? And so some of that is you're seeing higher out of pockets, you're seeing higher deductibles, the premiums are going up. We have things like the employer mandate that are kind of containing premiums, but what's kind of interesting is, if you're charging $100 a month in premium 1 month or 1 year, and then next year you're charging $150, it doesn't sound like a lot, but when someone notices an additional $50 coming out of their paycheck,
50% increase in that person's mind.
Yes, they notice it, right? So it's
what? Yeah.
Yeah, well, and that kind of ties in a little bit with some of the other news that you and I were discussing, where they just announced 10,000 employees at HHS are going to be laid off. That's the plan. We've seen some back and forth with some of those layoffs. They say they're going to happen, then a judge orders that they can't happen. Some things like that. I think when I was reading the article, and correct me if you know the number better, I think they were only saying that 300 from CMS.
I have not looked at detail on that. I really view that as a it's typical of kind of what's coming out of DOGE. Right now is, well, let's go after federal employees first, see if we can reduce the workforce. Secretary Kennedy had indicated he wanted to do that. So the 10,000 is a big number. The cuts don't surprise me, but the reality is, with healthcare being the number one expenditure by the federal government, it is not HHS employees. That's not where the money is going. The money's going to the federal entitlement programs, federal insurance programs, Medicare and Medicaid. I mean, that's really what is driving federal debt, because it is the healthcare is the number one expenditure by the United States federal government, and
by a
it
long
goes
shot.
by a long shot. So if you and then after that comes Social Security. So it's all these insurance and retirement programs is where the money is. If you want to save money, you've got to attack these underlying insurance programs. I just don't know that they want to touch Medicare or Medicaid. I mean, what are your thoughts there?
Well, and so, one of the things that you had pointed out before was that more people are covered by Medicaid than are covered by Medicare, right? Whereas in the conversations, it always feels like the Medicare reductions are kind of the third rail. Like you're not going to mess with Medicare, partly because older individuals generally vote more, right? So there's a
I, I,
motivated.
I used to say that yes, Medicare participants vote in Florida sometimes twice. It is a voting population, it's a politically active population. And with Medicare, even people who don't have Medicare yet, they maybe have a parent who has
Yes.
Medicare, and they're sure trusting that one day they will be Medicare recipient. So Medicare really is, if there's anything that's almost untouchable, it's that.
And we'll talk about why that's interesting with the Medicaid piece, but something you just said I thought was interesting when I'm talking to people on the, on the plane, talking about what we do and all of that. It's amazing the number of people that will ask me about their parents' Medicare. Do you think anything's going to happen to my parents' Medicare? It's not about their coverage or anything like that. It's about, mom or dad's Medicare. So I think there's definitely something to that. What I think is also interesting is that when they talk about making changes to Medicaid, there are a couple of different ways that they could do that without people realizing that they are the ones that will be impacted. One of
Yeah,
the things is,
let me do a quick Medicaid primer,
let's
because
do it.
I'm going to guess some of our audience is like Medicaid. Yeah, I know it's a program for lower income Americans, but what is it? How many people are covered? There's almost 90 million people covered by Medicaid.
Huge.
A big part of the Obamacare expansions, cover expansions, were the expansion of Medicaid eligibility on a national basis. Not every state has expanded.
Mhm.
Texas, where I live, one that has not. So that expanded the number of people covered by Medicaid, and Medicaid is partially funded by the federal government and partially funded by states. So it's a shared financing program, both on a federal and a state basis. And bizarrely, every state does not get the same amount of money or the same percentage. The federal reimbursement actually varies by state based on a number of factors. So that's kind of what Medicaid is.
And then within that, states will sometimes have different Medicaid programs or different programs that are funded by Medicaid. It's not always called Medicaid, right? It's called MinCare in Minnesota or something like that. So you have these different names that it goes by. And so sometimes when people talk about Medicaid cuts, again, I think for individuals out there, they're not connecting the dots that, oh, wait, they're talking about the program that my child is covered under, right?
Yeah.
And so you have that part of it. And then the other interesting layer to it is that there are ways that they can start restricting the Medicaid expenditures without, again, explicitly calling it a pullback, right? The first one I thought of was, the work restrictions, things like that, where if you make it more difficult, especially for some of the lower income individuals to qualify for the program, to go through the paperwork and all that, you are going to see a reduction in the number of people covered. But the one that you brought up that I thought was really good was you just change the way that you're providing the money to the states,
Mhm.
right? Go ahead.
Yeah, I think that's the big opportunity and really fits with the Republican approach to most issues, economic or legislative or legal or anything else, is hey, states' rights. Federal government's, taking too much space and states should have more freedoms. Well, this really sets up for, I think, the Trump administration to try to reduce the federal deficit or federal deficit, annual spending deficit. Can't The debt is what it is.
Yep.
By doing that, I mean, the most consistent way to be would say, hey, we're empowering the states. We're giving freedom to states to do what they want. And on the other side, they're capping or reducing what the federal government is spending to push more economic responsibility to states. I think there's a real possibility of that.
Yeah, you say we're not going to restrict these dollars the way that we have in the past, However, you're now going to see three-fourths of the funding that you'd seen in the past, right? And so in some states, well, maybe that's not a big deal. In other states that have a large number of Medicaid recipients that follow the federal guidelines and then some, there will be some significant impacts if they went that route, right?
It was very interesting. If you think back to the early days of Obamacare, which most of our audience will not recall, and that's a good thing, not a
I was
bad.
going to say good for them.
But the presidential debate, Texas governor at the time, Rick Perry, and most of you may or may, he had a terrible debate performance. He was on pain medications from a back surgery, and he quite frankly responded as if he was stoned. He had a really bad, but he said something that actually makes him, in retrospect, look really smart. He told President Obama, because what happened in Obamacare was the federal government committed to pay on an ongoing basis 90% of the cost of new enrollees, 100% for the first year, kind of trail down, but after that, forever. With expanded enrollment, federal government was going to pay 90% of this cost, not basically half like most everything else. Well, Governor Perry said, if I can get in the legislation that is evergreen and everything in this legislation is null and void, if the federal government ever backs up that commitment,
Sure.
we're in. At which point the Obama administration said, under current rules, it would be 90%, but not, no way to commit to forever. We will never drop this. I think Governor Perry kind of knew, hey, fullness of time, federal government can't afford to take all this on. It's a shared responsibility program, and I think that's going to come into debate here reasonably quickly.
Yeah.
Quietly, though, this will not be a loud public debate. This will be a behind closed doors Washington budget discussion item.
It'll be in terminology that we will be looking through the legislation. We'll be looking through the reconciliation bill, and you and I will see something like, does that mean what I think it means? And I'll call you up and say, Den, does this mean what I think it means? Because it won't, to your point, it's not on the face of it going to be clear. It's going to be it'll be written in hieroglyphs.
Here's what it means for our clients. Because I think that's the big thing. Our clients are like, Medicaid, why do I care? I was in a discussion with the person who owns all managed care contracts for the I'll say one of the largest, so I don't give away who it was, one of the largest health systems, hospital-based health systems in Texas. I did a meeting with him a few weeks ago, and we were talking about reimbursement issues, and he was talking about everything they're trying to do. And here's kind of where the discussion went that of why they hospitals are watching this is, they feel that they are about break even on Medicare, more or less close. They're about break even on what Medicare pays. Medicaid typically pays them a little bit less than Medicare, so it's a low revenue. Hey, we don't want to there. In their Obamacare plans, when the insurance companies in the individual marketplace, they're getting between 120 and 140% of Medicare. So about 20 to 40% above Medicare. But if it's commercial insurance, what our clients are buying, they're 250 to 300% of Medicare. And so if this Medicaid budget gets cut, that's going to get pushed to the hospitals. The hospitals are going to be forced, because this is government healthcare, they're going to be forced, they have to take these reimbursements. That further puts price pressure on our clients who in Texas are paying 250 to 300% of Medicare. They're already paying a massive surcharge for the government programs. And that, if this goes this way, it will only get bigger.
And another kind of tertiary connection there too is a lot of our clients have employees that are covered by Medicaid. They're waiving they're lower paid full-time employees or whatever. They're waiving coverage, and that's because they currently qualify for Medicaid. When we had the rollback of the pandemic rules and people had to start recertifying for Medicaid and all that, we saw a number of clients where they had people coming in saying, I now need to get onto the employer sponsored plan. My Medicaid is going to be cut off. And so, yeah, if we see it go from 133% of the FPL to qualify for Medicaid back down to 100% or something like that, I have no doubt in my mind that we'll have clients that will have employees that were,
Yes, it
that
will
we're waiving that will ask for coverage.
shift enrollment to the employers. All right, we've gone pretty deep on this. It's kind of put a bow on it on the Medicaid discussion. So I think both of us agree that for the federal government to really impact cost in the healthcare space, they started with the HHS jobs. That's for publicity purposes. The real money is in programs. Medicare, they're really sensitive about touching. Medicaid has been quiet, but they were talking about it, quieted down the last 30 days or so. I think it will come back around as that. And I think the Republican response to that is going to be, hey, states' rights, states' freedoms. That'll be the terminology, but the reality will be they're going to push economic responsibility to the states to try to save federal government spending.
Yeah, if you're gonna continue the tax cuts from the first Trump administration, you got to find that money somewhere, and Medicaid is one of those spots where we're 90 million people covered by Medicaid. That's a lot of money.
That's a lot of
Um,
money.
so before we let everyone go, I'm sure everyone's like, please stop talking about Medicaid, move on to something else. And we're not talking too much about the executive orders. I did an article about the executive orders and how unless they are kind of backed up with legislation and things like that, there's not that much to them, right? But there were two that caught my eye that I thought were kind of interesting. One of them was President Trump did an executive order about pricing transparency rules and saying, I want the enforcement on this beefed up. And it was basically about the providers and the networks posting the cost of services, devices, things like that. And they want an actual dollar amount. They don't want a range. They don't want an estimation. They want an actual dollar amount. Uh, I'm a big fan of this one. I like the transparency rules as they are. I don't like sometimes how they're kind of trickled down or pushed to our clients to try to comply with them. It should all be on the TPAs, the carriers, the providers. But you and I know that the more information we have, the better that we're able to look into the different provider networks and see how much they're charging for their services, the better analysis and the better consulting we can provide to our clients. So I like this one.
I I think saying you're against price transparency in healthcare is almost like saying you're against your mom and apple pie. I
Yeah.
mean, it's hard to say it's a bad idea.
It's hard to say it's a bad idea. Again, it's all in the execution. I
Yes.
could do an entire podcast about how some of the transparency requirements that our clients have to comply with. I want to, yeah, I get a little frustrated over it. There's that one
Yeah.
also.
Unfortunately, transparency doesn't mean simplicity.
Yes,
And the
that's a good yes.
complexity of healthcare, the complexity of the ICD-10 billing system, which is an entire coding language, it's really hard for somebody to navigate that. But anything is better than nothing.
Yeah, well, and I was just kind of thinking about this will mean something to a lot of people listening. RxDC reporting stuff like that. Where, gosh, couldn't we have found a way to just take the plan sponsor out of it? Like the information's all coming from the PBMs, whatever. Like, did we have to put it onto the plan sponsor? Setting that aside, the last thing that I wanted to talk about was also just as we're talking about tariffs and all that. Turns out we do import drugs manufactured in Canada. And so, there's now articles coming out about increase in pharmaceutical costs if the tariffs as they're currently structured go through, and if there isn't an exemption for pharmaceuticals, which, as you and I know, pharmacy costs is like one of the biggest ballooners of our current medical spend, right?
It pharmacy and eggs. Yeah, eggs people were talking about because it was at the grocery store every week. Pharmacy they weren't talking about because you don't see it unless you need that drug. But if we look across our industry and across all of our clients, the increase in pharmacy spend and the ongoing increase, in spite of some great efforts to contract in new ways and get better arrangements and that, it's virtually impossible to keep up with pharmacy
Yeah.
inflation. Yeah, high inflation item.
And
The other thing that on the tariffs that I think we need to watch on that is under prior administrations, not putting this on the Biden administration, it goes back it goes back a ways. But there's been a big move in the pharmacy industry for manufacturers to move to Ireland. Their headquarters are in Ireland, not in the United
yes,
States, because of the tax rules. Well, now those companies that have gone there are we going to have a tariff because we're having to re-import drugs that people think are from American companies that are and not on the manufacturer side. But one of those, as an example, is Walgreens.
sure.
Walgreens was founded in Chicago. they're not an American company anymore because they moved for tax purposes. They moved their headquarters when they merged with a European pharmacy company. So there are a lot of stakeholders in that pharmacy chain that actually are not domestic companies any longer.
Yeah, well, that's just on the pharmacy side. When you think about the amount of medical equipment and things like that that are manufactured in places like China, I haven't seen anything. I could be wrong, but I have not seen a single article. I haven't read anything that exempts medical supplies from the tariffs. And so when we just look at those dollars and cents as it starts adding up, right? If each piece of plastic that goes in the hospital goes up by 20% in cost, at some point, I would imagine, will notice an increase in costs, assuming that the tariffs stay in place in their current form.
Which we know won't happen, but we don't know what will happen.
Now you said that, you know that they are going to stay in place in their current form, and that's going to be the shocker, right? Um,
It's I think that's everything. You look at the stock market, you look at other
yeah,
things, and no one really knows what the end game and all this tariff discussion is going to be. But it is very clear if medical devices and pharmaceutical drugs are not exempted, there will be a direct cost impact to our clients.
and we'll be watching that closely. And I think with that, we'll call it a day. We appreciate everyone joining us today. As we always say, it doesn't have to be the end of the conversation. Den and I love talking about this stuff. If you want to hear more, if you want to discuss it more with us, reach out to your Holmes Murphy representative. They know how to get in touch with us, and we'll jump on the phone with you. But thank you very much for attending.